see him on here.
Yeah. 1, 2, 3,
Right.
4, 5.
Okay, it is,
Be in the document or-
are we ready? Okay.
When you are.
It is 11 o'clock, so as I am vice chair, I will call this meeting to order. And hard for me to, maybe we'll go around the table and then,
Oh, for introductions?
yep, introductions. I'm Peggy Van Buskirk and I'm representing Hospital District 2.
Sharon Trask, Mason County Commissioner, District 3.
Randy Nevlin, Mason County Commissioner, District 1.
Dave Wyndham, Director, Mason County Public Health and Human Services.
Eric Onisco, City of Shelton, Council Member, seat 4.
He takes notes.
Pat Tarswell, Mason County Commissioner.
And
Pam Schlatteroff, Mason County Hospital District Number 1.
I don't know.
and
Steve Greer, Health Officer from Mason County.
Oh, Ian's right there.
Ian, you're there. And we have Melissa, but that's not Melissa, is it? It's,
I'm here, yes. I'm
Okay.
Melissa, Community Health Manager.
and we have Ben Johnson and Vladimir
Staff is sick.
and,
Yep, Ben Johnson, Mason County
Oh,
Public
no, I
Health
was in the
Coalition,
office the other
Substance
day.
Use Prevention Coalition.
Tamara.
Tamara.
and Tamara.
Hi, Tamara Ingwaldson with New Horizon Communities. Just popping in to visit.
Okay.
I'm turning myself off.
Please.
And then we have Constance. So,
And Louis.
so did I miss anybody?
What's that? Do you know that?
Do you have one?
Okay,
have one.
approval of the agenda.
Madam Chair, I move we approve the agenda.
I'm sorry, second, I can't hear, I got 3 things in my ear.
Okay.
Second, I approve the,
Okay.
approve the
Any-
agenda.
Any discussions?
Yeah, I have one thing to add to the agenda,
Oh,
if I may.
okay.
And that's a quick discussion on Kratom.
Okay. And where do you
Where do you
want
want
to?
Agenda?
And let's put that,
Other business?
yeah, other business is fine.
Okay.
Yep.
Okay. Any other discussion? Hearing none, all those in favor?
Aye.
Aye. Okay, any opposed? None? Passes unanimous? Okay.
Oh, I'm
approval.
sorry, I didn't see it in there.
The next one is a resolution to set the meeting dates. And I questioned the July meeting because it's the 3rd Tuesday instead of the 4th, and I don't have a problem with that. And also the November meeting, it's the 2nd instead of the 3rd Tuesday. So I don't care either way, but is there any discussion on that?
Is there a reason why?
That's what I was asking.
I think in November, we rolled it up a week.
But that would be 2
What's
weeks.
that?
The 10th would be 2 weeks,
That
not
would be 2
one.
weeks, right.
Yeah,
So
So I wasn't-
Mackenzie set these, and I haven't gotten back with her on it.
and I don't care either way. The
So-
dates are fine with me as proposed, but
When
does
is the
anybody
July one?
else have a?
July was what again?
July was the 21st instead of the 28th. And November was the 10th instead of the 17th.
Well, on the 21st, we have MTA and a regular commission meeting.
So maybe we should change it to the 28th.
Yeah, I think 28th is more open.
Okay, so let's change that one to the 28th, and what about the November?
Okay.
Is that a briefing day for you guys, though?
Next
I mean,
Tuesday.
November, we had on the 10th, okay.
Oh. What day am I on?
I don't know.
Because the
Yeah, yeah.
17th would,
The 17th would be the, I think, the more correct.
yeah,
Yeah.
the 17th would be the 3rd,
Oh, got it.
Okay, yep.
so let's change that one to the
Okay.
17th.
Yes, that still puts us a week off of Thanksgiving, so.
Yeah, so that
Okay.
works.
So do I hear a motion?
I move to approve the calendar as amended.
Second?
Okay, any other discussion? Hearing none, all those in favor?
Aye.
Aye. Any opposed? Hearing none, passes unanimous. And
Did you get a
then,
vote from Cam?
Yeah, she
Okay.
said I heard her.
Somebody up there did.
Okay,
I forgot my hearing aid, so I'm a little disadvantaged.
election of the officer positions.
I move to nominate Eric as board chair.
And I would second that if he's
I'll do it.
not opposed.
It's fine.
Any others?
Yeah, there you go. You gotta ask for it 3 times.
Okay. Any others?
That's the third one.
Okay. So, all those in favor?
Aye.
Aye.
Pam, do you have a? I couldn't.
Aye.
Okay. So Eric, you want to take over the meeting?
Sure.
Okay.
Right. Item number 5, approval of November.
Let's do a vice.
We need a vice chair.
Oh, yo. We do.
Sorry.
All right. Is there any nominations for vice chair?
Well, I'll nominate Peggy. She did such a fine job.
I don't mind being a vice chair.
All right, I'll second that. Any others? Any other nominations? That's 3, right? All right. All in favor, say aye.
Aye.
Aye. Opposed?
Aye.
Motion carries.
Heard you, Pam.
All right. Now we're on approval of November 25 minutes. Has everyone had a chance to read the minutes?
I make a
Yes.
motion, we approve the minutes as presented.
I'll second.
All right. Any discussion? There's a motion and a second to approve the November 25 minutes as presented. All in favor, say aye.
Aye.
Aye. Opposed? Motion carries. All right. We're at health, item 6, health officer report. Steve, you have a report for us?
I do, thank you. It's good to see you all. Let me pull my slides real fast. And if I could share them, that would be great. Let's do- Alright.
Cammy, do you control if he can share or not?
So, there you go.
Good? All right.
Yeah.
Good afternoon, good morning still. So yeah, I'm Steve Greger, health officer for Mason County. Happy New Year. I can't believe it's 2026 and we're almost into February. Couple things. I think from a kind of infectious disease, public health standpoint, we've been, the last year concerned about measles. We had a little bit of lull, I would say, over the summer in terms of just nationwide measles cases. But I did want to focus on it because we've seen some cases locally, including some transmission. And I wanted to briefly talk about it, kind of give us some things to look for and things to be thinking about. There we go. So, just recently, about a week and a half ago, a measles outbreak was declared in Snohomish County. They've had 5 cases associated with the outbreak. It started with people traveling from South Carolina. I think there were 3 cases that were identified in Snohomish County first, and then, but those were all travelers. They went back to South Carolina, but they had spread to 5 other people and 1 in Kittitas. The Clark, there was just a case announced in Clark on Friday afternoon, late afternoon, evening. So that is still ongoing, and I haven't read if that's connected with Snohomish or South Carolina. I'm not sure they know exactly where that person got measles yet. The large outbreak in South Carolina is probably like the most concerning thing happening in terms of the country. It's about as big as the Texas outbreak last year, and it's been growing very quickly. I have a graph I'll show you kind of how fast the line is going up, which is concerning. Obviously, I'm going to talk about this a little bit too, but measles investigations are complex. You have a very contagious illness, and it's airborne, which means kind of any space that person goes while they're contagious, is potentially somewhere someone could have gotten infected, especially if they're not immune to measles. The State Department of Health has put together this nice map where it talks about where public exposure locations happen. So this isn't everything. If there was like a private party or a home or something like that, that's usually, we work through that in kind of, you know, a private manner. But if it's a public location, in a school, supermarket, a gym, something like that, we do want to notify, because we don't always know all the people in those locations, right? And so we usually, the state as well as the respective county where it happens will kind of make public announcements about, hey, there was a contagious person in this location at this time. If you happen to be there, you know, watch for symptoms, especially if you're not immune. I just wanted to zoom in on the more recent one. It did happen at Ridgefield High School in Clark County. They will, when you click on this dot on this map, it'll show, you know, the location, it'll show the dates. Sometimes it'll show times if it was just a brief period of time, like 3 hours or something like that, and then some links about what to do, you know, if you were at that location. State Department of Health has some good links here to read more about measles in general. But I like this map. It's new. I think it was just created a few months ago, so it's kind of nice. You know, people are worried, was I in a place where measles happened to be? You can look at this map. Hopefully we will, you know, keep these dots in low numbers going forward. This is that graph I was talking about. Sorry, that measles in Washington should not be there because this is just measles cases in the United States. Apologies. So if you look, especially the last year, this is kind of measles we've had, you know, over the past couple of years. A huge increase in 2025, and then unfortunately 2026 is starting off even worse in terms of the number of cases that we're seeing weekly. So South Carolina is driving that, but we'll kind of see where that goes over time. One thing we don't talk about as much is, you know, obviously we have this health component. We want people to be healthy. You know, measles has, you know, significant risk of hospitalization, about a 1 in 1,000 risk of death. But there's lots of other impacts, right? And, you know, Clark County is seeing this, Snohomish County is seeing this, where an exposure happens, and then you know, there's a huge public health investigation, and then people miss work, miss school, and then there's also this huge kind of financial cost. I found a couple articles talking about this. An average cost per case in an outbreak was estimated to be $43,000. This was from a bunch of different papers. Average cost per contact was $443. So a contact being someone who was exposed to a case. Our Clark County partners did a analysis of their response in 2019 when I think they had around 70 cases. And the whole response was estimated to be around $3.4 million in societal costs. That included days off of work, but the biggest bulk of that cost was actually health department costs, so like overtime, time worked on the, and mostly like staff time working on the investigation. It's a very intensive investigative process. It takes a lot of time. This is a little bit outside my lane, but obviously we think about funding in public health. We know that there's going to be challenges over the next year or so, especially with foundational public health services money, and it makes me just a little bit worried. Okay, last slide. We consider someone immune to measles if they were born prior to 1957, from which everyone at that point had probably had some exposure to measles. If you have a documented past infection or 2 doses of measles, mumps, and rubella vaccine. Last thing, if you think you may have been exposed, you're worried about being exposed, and you develop symptoms which start out pretty mild, like a cold, cough, a runny nose, red eyes potentially, but then develop fever and then kind of a classic rash. One thing I want to emphasize for people is thinking about calling ahead. So one issue we see all the time in these investigations is someone is sick, they feel really bad, they go to they go to an ER, and they go to their urgent care, or they go to their pediatrician's office. They sit in that waiting room, they don't have a mask, and then they expose everyone, right? In that waiting room, they end up testing for measles positive like a few days later or something like that. So that makes a lot of work. It also exposes, potentially all those people in that location. So calling ahead is just one way. and being specific, like, hey, I'm a little worried that I might have immune symptoms. If I come in, what should I do? And they might have you wait outside in your car. They might bring you back into a room right away and put a mask on you. There's different ways to kind of try to reduce spread. So I just want to point that out as a kind of a practical thing people can do to kind of make things easier for everyone if you think you have measles. That's the slides that I wanted to share. I know we have a lot of other things to cover, so I'm going to pass it off and see if anyone has any questions.
Any questions? When did they quit doing measles immunity or vaccinations, or are we still doing those? We still do those.
We're still doing
So,
absolutely.
so
yeah.
are we still able
Yeah.
to get measles after being immune or getting the shots?
Yes, great question. Every kind of guideline, including the CDC, still recommends measles vaccination. Most of the time it's recommended at age 1, like 12 months old, and then age 4 to 6, hopefully before kindergarten. So that's still recommended. I haven't heard of any issues with access, and it should still be absolutely covered by insurance. So yeah, I highly encourage that for people.
And this is airborne, not just touching stuff, or?
Yeah, I think we think it's primarily airborne. There might be a surface component, but that's again what makes it really problematic. It can stay in the air for up to 2 hours after someone leaves a room. It can spread pretty efficiently, especially in a small room or with poor ventilation.
Thank you. Any other questions? Thank you.
Thank you.
All right. Item 7, administration reports. Dave?
Okay, so kind of starting from the top. On our board positions right now, we are full on, we've got the 3 county commissioners and the 1 city, so that's the base of the local board of health. But under the expansion of the board of health, now we expanded our board years ago, and really met the number criteria, but then the state came back and said, okay, now you're gonna have categories. So the new categories were medical, and we have that filled with Peggy and now Pam. I filled the medical piece. We have under community, we've got 1 tribal member, and then we've got a secondary for that, and that's from the Squaxin tribe. So we still have 1 community member, and that's a community member at large. Typically, that's a community member that utilizes public health services. So septic designers, or people who have that business interaction with public health. And then the last category, which we've had the toughest time recruiting to, are the consumers of public health, and that's you're somebody that goes to the WIC clinic, or other things that public health touches, and we've just not had any great jump on that. I did have somebody call me this week, and I called him back this morning, who's interested. I have to figure out where he would fit into that and get him an application and get him to come in and talk to the county commissioners. So we'll get that one sent out. So,
Dave?
yeah.
On that one, for the consumers, could that be like nonprofits, because they help people
Right.
get those? So it's not just somebody that uses the WIC or something
Right,
like that.
it's
It's somebody
cons-
that helps others.
Yeah, consumers of, so yes.
Okay.
And I'll shoot that out again, because I think it'd probably be a good thing for the board to know, because as you're talking to people in the community, and you say, hey, I'll get you the criteria.
Okay.
So,
So maybe we can share that with our nonprofits.
yep, can do. Okay, so there's that. Fiscal, all right, this has been a lot of work the last several weeks. So, and it kind of rolls into my next thing, I think, which is no, it's not on there. Okay, fiscal. So the governor's budget came out. And the governor's budget includes a $50 million cut to public health. And that includes 2 pieces. That's a cut strictly to Foundation Public Health Services. There's also last spring, during the spring session, they redefined some of the items that were in the vape tax category, which helped fund public health, as tobacco. So move them out of the vape fund, which supports public health, and into the tobacco fund, which supports other things. So we lost about $4.5 million there. So across the
Statewide.
system.
Yeah.
Right, so when you roll all that stuff up together, it comes up to just shy of $50 million across the state. Excuse me, I'm the chair of the Executive Leadership Committee for all the health directors and administrators. And it fell into my lap to allocate the cuts. That's been a rowdy discussion the last couple of weeks. How do you allocate cuts across the state? And really, I'm pushing back because at this point, the legislature is not bound in any way to follow the governor's budget.
Right.
So I think we're jumping ahead of things to try to figure out how to allocate cuts when we don't know what the cuts are gonna look like until March 12th, when the legislature ends and they've done their wizardry to budgeting things, and we see how that lands. So there are some legislative fixes going in for the vape piece. So there's 4 different pieces of legislation that would fix that. And those all got hearings last week. So they have until the 4th is the first policy cutoff, and then the 12th is the House of Origin cutoff, and I think right at the same time, the 14th is the budgetary cutoff.
Yep.
So by the end of 2 weeks from now, it'll move over to the other house and see where those bills are going to land and how the fixes get made. I said years ago, it's a mistake attaching a permanent funding source to a sin tax. Because if people quit smoking or quit doing whatever the sin tax is, then you lose funding anyway. So, levels above me. So what does it mean for us? Last June, we took a 19.8% reduction in foundational public health services. So we went from 2 millions, over 2 million. 2,200,000. Now we're at 1,700,000, so we took a $500,000 cut. So we absorbed that by not expanding our programs. We were set to start family planning, so we put that on pause. We stopped our hepatitis C program, which was another nurse position. So we saved that money by not fulfilling the things that had already been approved for us to do. So we dialed back the expense of that. We do not have the ability to do that again. So if we lose more funding, it will be positions. There is just no slack in the system anymore. So Casey and I are on top of that. He's working right now on projections for the rest of our fiscal year, which goes to July 1st, and how much of our FPHS funding are we going to tap. And the goal is to tap all that FPHS funding first. And really it's 32.5% of our total budget is that fund. So for public health, that's it's a big thing. And last year, because we didn't spend it, because we hadn't filled the positions, they took the money from us, gave it to other health jurisdictions who were who were better at spending funds, and then they spent the funds. But now we're back to everybody's at square one again, and having to have those discussions yet again. We finished this year very well. We came out below budget on expense and just slightly above budget on revenue, so we did okay. And part of that was from not filling those positions, which kept our expenses lower. And we've had we just had a pretty good year of capturing that revenue that we would normally get. And I sent out to everyone the packet. So I think the first chart shows revenue over time, and it's fallen back into a typical pattern like it was before COVID. COVID messed up. You couldn't predict anything during COVID. So now we're back to more of a standard funding pattern. We're looking pretty good. Our budget for part of our budget reserve looks really good, but incorporated in that reserve is also the opioid settlement fund and the treatment sales tax. If you take those pieces out, in the reserve, I've got about 2 months in reserve. So typically, in a non-long legislative session, that's fine. When you get to a long legislative session, you can burn through that in July and August while the legislature and the Department of Health are still getting their acts together to get our contracts out to us.
And we have before.
And we have
Yeah.
before. That's our ability to coast. So we have the ability right now to coast for about 2 months. I don't think we'll need it, but it's there if we do. So we're doing okay on that end of the finances. This could be anything. It could be a $5 million cut. It could be a $10 million cut across the system. And then how we allocate it out to the health jurisdictions is going to be the big argument between March 12th and really about the 1st of May, when we have to get those contracts in to DOH and get them out as a statement of work to us. We sign off on them, they go back to DOH, and the contract is written. So there are a lot of pieces that have to fall in place really fast after the legislature ends. So, and many of those fixes that they're going to put in, we won't see until fiscal year 27. So if they fix the vape account, it's not gonna happen until next year. If they add new taxes, we won't see any of that at least until 27. So it's gonna be just seeing where the legislature makes the cuts and then how do we allocate those cuts going forward. So it's gonna be a rockin' spring of 2026.
So do you think that a letter from this board to the governor's office and legislators would probably be helpful?
Yes, so a legislative letter from here would be very helpful. The governor said he wasn't gonna budge, so I wouldn't focus any effort that direction. I would focus it on the legislature and say, let's try to maintain as much in the FPHS account as we can. It's not gonna remain whole. Let's just be honest, it's not gonna happen. So, let's approach it from a place of saying, let's keep it as whole as possible. Part of what I've been doing is trying to, in the allocation piece, is how do you allocate the funds in such a way, excuse me, that the smallest health jurisdictions have a floor that they don't go below. And then the extra cuts would come out of the larger health jurisdictions. Of course, I get a lot of pushback from the larger health jurisdictions.
King, Pierce, no.
Yeah, so we'll see where that goes. But my goal is to keep as many of the smalls and mediums like us. We're on the low end. We're in the smallest of the mediums, and keeping a floor for us that we can maintain the services that we've had. Otherwise, we wind up rolling clear back to 2019 funding levels. So it's kind of where out. So I can shoot. I've got a pre-packaged letter. I'll get to you, and then we get to the board.
So do we concur that a letter from the board to the legislatures would be?
Yes, and we need to get it out soon though.
Yeah.
Because they're in session.
And they're already meeting on the budget,
Yeah, so it needs to be sooner rather
So
than
can we
later.
approve the letter via email and then maybe sign electronically?
Okay,
Sounds good.
I can make that happen. Okay. Next on here,
Sorry, Pam, you have anything on that?
No, I agree.
Okay.
Thank you.
okay. The pilot program that's the mental health pilot program is wrapping up as of the end of February. So they had agreed to go 90 days and they took it to a year. So they have provided mental health services for a year. We learned a lot during the process. We learned what works, what does not work. We've had like 2,500 downloads. We've had just tons of engagements. We've had, I think, 4 or 6 suicide interventions. So good news on that. And we learned what motivates people to click and do things. We found that newspapers and radio is great for putting out information. But if you want people to actually click on something and to do something, then it's Facebook ads, TikTok ads, where people have their phone in front of them and they can go boop, and now they get the download and start interacting because that's the people who are going to do it anyway.
Yeah.
So we learned a lot there. So that will save us money in the future to not go places that we know they'll work for us. We're actually going to be presenting at the Washington Rural Health Association about the pilot program. And for those who don't know, the pilot program for mental health was through a company called United We Care, and people were able to access it with their cell phones, no cost. And AI starts the process, and then if you feel the need, you're able to access a licensed therapist, counselor, or health coach, a live person, licensed in Washington. So lots of people took advantage of that. And just for fun, I went through it. I put like a typical day for me in it. And on the AI piece, it says, would you like to talk to somebody? So I thought, wow, it knows me so well. But it's been, I think, a pretty good program. We learned a lot about how to reach people. The goal that I have is getting people health care in the communities where they live. So they don't have to travel. They don't have to go other places. And I think as we go forward in time, it's going to be, how do we become innovative and get those things out to folks in a way that they'll use. So that's kind of the wrap up on the pilot program. Going forward.
Can I ask a question,
Yeah,
Dave?
yeah.
How was that funded? How did you pay for
So
that?
we paid that through the treatment sales tax.
Okay.
Yeah. So
And are you going to continue beyond the pilot?
no, well, yes and no. So no for us. Yes, we're going to try to take it statewide and use the Rural Health Transformation Program funds that just came out from the feds, 181 million that's going across the state, and to see if we can, because it specifically talks about using technology to reach rural communities and looking at how can we tap that fund to do this and to do other things in the rural communities. How do you get people blood work remotely? How, there are all kinds of new technologies out there that we can use to get people what they need where they live. So that's where we're headed next, Pam.
Thank you.
Mm-hmm. And then lastly, for me, I think, not me,
Trying to turn it off.
I'm just saying.
It's nobody calling, they're just trying to turn it off.
Lastly is the interlocal agreement, and this is a yearly interlocal agreement for acting health officer coverage. So if Dr. Krager is out and we need somebody, typically we do a contract with DOH, and Scott Lindquist falls in on us and helps us out. Scott helped us out a lot during COVID, so provided great support for us, especially when we were in between health officers. My recommendation is we have the board adopt it, and then I can have Eric sign it, and we can get that done.
All right, is there a
So,
motion? Oh,
yes,
go ahead.
I make a motion, we adopt the interlocal agreement as presented.
Second.
All right, comments or questions? Nope. We have a motion and a second to adopt the interlocal agreement for acting health officer coverage. All in favor, say aye.
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 Opposed? Motion carries. All right, Dave. Anything else?
That's it for me.
Any questions for Dave? All right, moving on. Environmental health report, item 8, Ian Tracy.
Good morning, board members. So I have the January report. I don't know if anyone has any questions about that. The main thing I'd like to highlight from that report is just the reduction in our solid waste code enforcement staff. It's more than a 50% reduction in our ability to do solid waste code enforcement right now. We hope to have that capacity back beginning in April, but that's where we are right now. As far as I think that's all the major ones for that report. Yeah, it's just that loss in capacity that we have that's the biggest impact to our programs right now. And that, you may hear from the public on, it's really, we have so many cases, we can just respond to emergencies, and in the solid waste world, emergencies are typically someone burning garbage. That's the solid waste equivalent of that. And then we are trying to keep some forward momentum on some of our real major cases that we're working on right now. But it's a lot of just,
What about getting some of your other folks and making them multi-modal, you know, different modalities that they can do, such as reaching in to do that, so that we have that covered more in the future?
the biggest problem is that code enforcement is not something you can just like hop into for a minute and then hop out. It's this long-term building of your case and having contact with a property owner and building up your interaction with them before you get to the point where you can say, all right, I've given you all of the warnings and information and education that I can, and now it's time to take you to court, or, you know, take whatever the next step is.
So, and I understand that, but that you run into that same problem if they leave. We have a different modalities for different people within our departments, other people doing it, you are able to keep that consistency.
The problem is that we have to start over. If we have like it's just like with a police officer, you know, if you have a police officer working on a case and that police officer suddenly is gone and all of their investigation, all of their contacts with people they interviewed, all that's gone, and you know, they can't stand in front of a judge and say, I swear under penalty of perjury, I saw this at this date, this
I
time.
get that, that's what I'm
Yeah.
talking about, it's the opposite of that.
Mhm.
By having some of your other staff being able to do other modalities and go in different areas, you don't, because you got that right now when the person left.
Mhm.
That's just how it is.
Mhm.
But if you have them doing different modalities and different people coming in, you have a better chance of keeping consistency. It's good
They're-
business to have.
Yeah, but they're always,
cross
they're always
modalities.
funded to do other work, so if you're doing that, then do you do
Then we're
not
not
do
doing something else.
septic permits? You know, what areas do you cut in order to do those things? So,
That's
Or
a third
again-
point.
Or again, spreading them out, and they can also do different modalities as well. Somebody else can be into that job, different modality. I've just seen it all my life, that's what we deal
Are you
with a lot of
talking
our.
like
our
cross
stuff.
training?
Basically, cross-training, yes.
So-
They have different modalities that they learn, so that they can do some of this and some of that.
And
Union
yeah.
would be the only issue that I see.
what was the only?
Unions would be the only issue I see to see, cross
Yeah.
unions or anything like that.
The union's not an issue because they're all in the same union. So.
No, I meant union description of job description.
Yeah, no, that's what I mean. They're all
I
under
addressed
the
that
same.
several years ago
Yeah.
by making them all environmental health specialists. But each of the specialists is also trained and certified in different things.
But your point is a good point. It just doesn't work out in reality. We've had times when our department was a lot smaller and we only had 5 environmental health specialists. Right now, we're about double that. But there have been times when we only had 5. And the problem is that the knowledge you need to be able to take on these different tasks is so specialized. And then when you have someone that's stretched really thin in knowledge base, you end up not getting a good product out of it at the end. You don't get someone who is either able to really stay on top of those code enforcement cases or really knows what to review in a septic permit. It's just, it's too much too thin. And then you have the problem with code enforcement cases. When you have a code enforcement case that goes from this person to this person to this person, you don't get any kind of consistent enforcement. You just get something that kind of limps along, and then that person's gone, and then the next person picks it up, and they kind of limp it along, and they just start talking to the person again, and then that person leaves, and then it hasn't worked out in practice, unfortunately, especially with code enforcement cases. You need someone who is well-trained in code enforcement to then take those successive steps, because when it drops, it's better for the situation. This is a temporary absence of this person. This person's coming back. It's better for them to start off where they paused than to try to have someone else try to start this case, because when it changes hands, there's this whole reconfirmation of the violation you have to do, and then you have to build that history with this property owner to start that again. It's not something you can just kind of pick up and drop off. I wish it worked that well, but our programs are so diverse. It just has not worked out in practice. When we've looked at the history of our department, we've had less staff for these. We just end up doing a lot of nothing in most cases. And then then there's this big focus on permits, because we have permits come in. That's something that's immediate. A permit application comes in, someone needs something reviewed, there's a turnaround time. If we don't meet a turnaround time, they complain to the commissioners or whoever, and then we hear from the commissioner, why aren't permit turnaround times taking us long? Why are reviews taking so long? And so then there's ends up being this big focus on the things that are like the immediate, like, oh, we gotta get this done right now. This code enforcement case, that's been going for years, we can let that slide, and that's what's, happened historically with those situations. Versus having those focused, specialized people that are actually able to take those successive steps. I wish we could space out code enforcement better, but it's really hard to do that.
I'm looking at the minimum qualifications for the code enforcement officer one. It's a diploma or GED, but then you have all the certifications as well. So you have to be a certification related to code enforcement, building inspector, zoning permit, tech, property maintenance, housing inspector. So it's not like you can just hire somebody off the street.
And
And
that
an
one
associate's
is,
degree in planning.
that's
So
that's
code en-
DCD's position.
that's-
Ours is different.
That's DCD's.
But you're right, it's not just someone we can hire off the street. We do have a degree requirement,
What's the title for that job?
environmental health specialist. They're all under that same umbrella, which is why it gets so complicated, because we have septic, drinking water, food, solid waste, swimming pools, zoonotic disease. It's just, it's
Shellfish.
so, the shellfish. Thank you. It's just the range of knowledge is so broad, and the regulations and requirements are so complex that it's just, you just really get a really poor product.
Okay, yeah, so that's very different, because the environmental health specialist, a bachelor's degree, preferably in life science or environmental health or related field, 2 years experience in one or more environmental health program areas, and or a master's degree in environmental public health. And that's just the minimum, so,
Mhm.
okay. That was just from my knowledge.
Any other questions on the report for that topic?
On code enforcement violations, do you have to use the sheriff to write those tickets, or can your staff do that?
My staff write the tickets. If we do have a avenue where we can go criminal, and criminal involves the sheriff's department. It's usually the sheriff's department getting a search warrant, and then us executing the criminal search warrant, and then using that evidence to go along with the prosecutor to then
Got it.
levy criminal charges. That's usually that process.
Any other questions?
All right, so on-site standards. We have our on-site standards, the environmental health on-site standards is a accessory to the on-site septic regulation. So it's a policy document that's adopted by our code as code. So it's enforceable as code. And it is typically the portion of our code where we get into specific details about the construction of a septic system. And we have two changes that had been proposed, and these changes have gone through our on-site sewage advisory committee. The first change was clarifying language around the requirements around pump systems. That was something that was voted on by the on-site sewage advisory committee, had unanimous support from those members, and is supported by our department. The second item is an item about drain field reductions. So there are certain technologies or RSMGs that the state has set, where they've said you're allowed to make the drain field smaller in certain situations by a certain percentage. For instance, if maybe you've heard of infiltrators, they're like this kind of half-dome plastic thing. In certain soil types, you can go down to a 40% reduction in the drain field, which is a very large drain field reduction. Historically, our department has not supported that, and we put that change in, I think it was somewhere around 2008, something like that. But we put that change in place specifically because of infiltrators. We had some infiltrators that were installed, and then that ended up being very bad. The person did not have enough drain field area, failed very quickly. So we decided that we weren't going to allow drain field reductions. The on-site sewage advisory committee had brought up bringing back drain field reductions in certain situations with certain technologies. But at the last meeting, they changed the way they wanted to go with that and decided to just eliminate the drain field reduction completely, the prohibition on drain field reductions completely from that policy. This is something that was not unanimous, and our department does not support it. So it's up to the Board of Health whether to approve changes to that policy or not. Our recommendation is to adopt something that's more of a middle ground, and we have some proposed language in here. So I'm not sure. The other option is you could say, take this back to the on-site sewage advisory committee, discuss it again, and see if we can come to something that everyone agrees with.
Or we could take their recommendation.
Or you could take the recommendation. Yeah, sorry.
This is an odd situation. We have a citizen panel that came together with experts and stuff like that on it, right?
Mhm.
And they're giving us a recommendation. Our staff doesn't like the recommendation, I appreciate that, but
Yeah.
it should have just as much weight,
Oh,
if not
absolutely.
more, than our staff's recommendation.
Yeah.
Where would this matter? Like a lot in Timber Lakes that's 4,000 square feet, it's not large enough for a normal septic system or drain field, so that lot now is just a lot for somebody never really to be built on, or?
Not necessarily.
Okay.
This is more like here's where it could go wrong, and here's where the department doesn't support it. An example would be you have a shoreline property, and someone is making a development decision on that property where they're like, I could put in the appropriate size drain field, or I could make the drain field smaller, and I can make the house bigger, and I will get more resale value on that property. The financial motivation for the development of a lot of small lots is going to be for maximizing what's going to sell the best and not what's going to be better for long-term viability for the property when it comes to use of the drain
Well,
field.
another option might be somebody that has a piece of property, their system has failed, and they don't fit in that regular footprint right now with the new requirements and stuff. In order to maintain and still live in their house, they may need to have that shortened type of high-end system in order to.
In general, no. The repair regulations are extremely
Not
loose.
replacement, they're looking to replace, there's one in particular
Okay.
that I'm talking about. I brought it to you guys when we were talking about it. That's a perfect one for what you're talking about right now.
It's not. That one's not.
If he was able, because his didn't have the drain field over on the side, didn't have the ability and the square footage. If he can go to a shorter drain field, that might help them.
It wouldn't, not that one. The situations that you're thinking of are not gonna really benefit from this that much, because in most situations, we will let them put whatever will fit on their property. And for that one that you're thinking of, that's on 106, that one doesn't have any place to put it, period. They have 0. So it doesn't matter how
I'm
much.
not trying to get it for them anyway, that's not what I meant.
Oh, no,
It's just the idea of the.
Yeah, no,
I'm not-
what I
Definitely
guess.
not advocating
Yeah.
to get that one through, because I haven't talked to him since that day.
I'm not saying that. What I'm saying is in situations where a property has a failed septic system, the requirements for the regulatory requirements in those situations are greatly reduced. We call it, like keeping grandma in her house, basically. We don't want to put burdens upon that person that are so great that they can't do anything. When it comes to repair regulations, there's a category that we have to meet, and then everything else is just do it if you can, when it comes to the requirements.
So what is our panel reason for recommending doing away with it? What's their argument?
Their original reason, the way the discussion happened was kind of weird. So we started out talking about this item over months and months, and we were working towards the language that we have proposed today, the one that's in the packet here today. We were working towards that language, and then at the last minute before we were going to vote on adopting that language, a member from the public who was there just raised their hand and said, you should just get rid of it. And then before you knew it, one of the members was like, oh yeah, we could just get rid of it. And so then they said, well, I make a motion. And then they voted, and it wasn't, like I said, it was not a unanimous decision by the group. There were 2 nays and 1 abstention. So it was strange how it happened. And then when I explained to them that the department didn't support this change, they said, well, maybe we can undo our motion we just made to accept this. And I said, no, I mean, you voted to make the change. You made the change. Now it goes before the Board of Health. You know, that's your recommendation. And so it was not a clear, firm decision by the group in general. It was strange how it happened.
Can we send it back to them for reconsideration?
That's what I would
Okay.
propose.
That's what I would propose as
Is it
well.
reconsideration or just further
For
discussion?
clarification.
Yeah.
And clarification.
Yeah.
Because,
Because it sounds like they didn't really think it through.
but at the same time, that's our staff who is against its opinion of that, we need them to say that. That's not
Right.
appropriate for, because this is a real odd situation. You're going against what the recommendation is, and I appreciate that, because that does happen, and quite often we go along with the staff over that recommendation, but there's no side here to where we hear what they're doing and what they're saying. And I personally would like to hear it, so.
And I invited those members that were strongly supportive of this to come here today to speak, and no one's come as far as I've seen so far. So
Ian, how long did they discuss this topic? I'm just wondering, because
Well,
were they
we-
worn out and tired of discussing it? And so they
no,
just said,
we spent many months. Well, I mean, they're quarterly meetings, so we spent probably 3 meetings talking about this topic, if not more. No, actually, I think it was probably a whole year, because it was in 2024 that the technology came about, and we first started talking about that. It was this one specific technology that started the conversation. And then there were delays. People were supposed to look into things and research the technology and try to come up with some changes to the language that would allow it in certain specific situations. And then, like I said, this meeting, whether they should or shouldn't, there were members of the public that were just chiming in constantly that were not members of the on-site sewage advisory committee. And then motions were made by members that started it. It was definitely strange.
And as background, the State Board of Health is typically tougher on the 11 Puget Sound counties.
Right.
There are things that we're not allowed to do here that other areas in the state are allowed to do. Like in having a waiver for 1A soils. It's not allowed in the 11 Puget Sound counties.
So I think we're asking you to take it back to them for further discussion and clarification.
Okay.
At best. Now, that doesn't mean you don't have another opportunity, at a bite at the apple to convince them to switch it, that you do. They can make another motion after they've made the motion to change it.
Absolutely.
So, they could have been let to do that at that time.
Well,
Let them this time.
It was, in that situation, it was one person thought of making the motion, and the other member said, no, we've done it, we voted on it, let's move on.
Okay, well, then that's their choice too.
Yeah.
Just
Yeah.
sending it back, just eliminate their motion, just start
No,
over again?
no.
It doesn't. Okay.
No, we're just
They
asking.
can choose
for-
not to reconsider.
Yeah, they could do that, or they could do, but
Yep.
if so, can you request that they send somebody to make their, because
Yeah.
this is at
And-
odds
and
with
I
what
did
the
that.
staff is, and we do respect what staff says, but we need to have the sides of the citizens represented somehow.
And I did that this past time. I said that to myself.
Yeah.
I strongly suggest that, because we don't support your decision, I said I strongly suggest that one of you appears to be able to, support your side of it.
I mean, I definitely like to know more about the difference between the shoreline properties and other than shoreline, because I watched your meeting yesterday with your presentation from the water district and clean water district, and we don't want short septic or drain fields on,
Right.
you know, over the bay, you know, that fail in a year,
I was
so.
gonna say, that's the misnomer part that
Yeah.
I'm bothered by, because
Yeah.
it doesn't mean it fails. There's different things we like, don't like, that's
Yeah.
been the history of this county,
Yeah.
and where they've taken things that they like, don't like, sometimes it's because of people. I'm not saying that's what this is here, but that's why we need to have the full background on it.
Yeah.
Because you have these systems that will work for as long as the other ones. Which ones are which, I don't know that until it's brought before us, but let's just find out.
Yeah, and things like that are things that you could add in, like, let's say this motion comes back, you could say, okay, we'll allow drain field reductions, but not in properties that are within so many feet of the shoreline or over a certain acreage. There's a lot of,
Yeah, or with this, without this type of system that
Yeah.
is proven to work, because I do know there's different systems.
Mhm.
I'd like to get the breakdown on that actual system that started the conversation too.
mhm.
See what they've changed since all those years when.
It's an interesting drain field technology. There, you know, imagine a standard square bale, hay bale. It's just that, but made of these styrofoam sheets that are all baled together, and that's the drain field. It's really an interesting thing. But
20 years ago, it was experimental wood chips.
Mhm,
Remember the ones at the Salmon Center and stuff like that with that system?
mhm.
Didn't work, but.
Right. Yeah, and you know, we've seen, you know, proven technologies such as the infiltrators, if they're put into soils that are too sandy, just suck up water and become nothing but a big jello mold. You pull the infiltrator up and it's just this perfect mold of the yeah, and it's failed. So you have working technologies that don't work in all instances.
Um,
Okay, back to the,
That's all I've got.
Yeah. Cool. All right, anybody have anything for Ian? All
Well, I
right.
kind of do.
Oh, go ahead.
It's more for the board. I know that code enforcement is it's a hot topic. And so, in thinking about it and not getting much sleep over it, what I'd like to do is propose that we have 3 members of this board, the Board of Health, go to meetings once a month with Ian and his staff, so that we can see what's going on, know what's going on.
I'm definitely interested, I'll show up for that.
I wouldn't want 2 commissioners there, because then it becomes a public meeting. I mean, you know what I mean? Not that we're trying to hide anything, I just want
Yeah.
good
But we can also
communications.
trade off too.
If it's not on a Tuesday, I'd be happy to do it. Tuesdays are big days.
So do we need, does that need to be a motion? So that we.
what days are your code enforcement?
Do an invite.
We meet twice a month via Zoom on Wednesday. It's Wednesday mornings, right, Ian?
Yes,
Yeah.
every other Wednesday.
Yeah. We were thinking of having a separate meeting just for the board to show what cases we're working on and walk the board through what's going on.
The entire board, or just
The committee,
3?
just 3 people. And then we could show them what, you know, which things have been taken to court, because we had a kerfuffle over there this last month over how do you code something. Yeah, so, I mean, there's things that we need to bring out
Yeah.
that might be an appropriate way to do it.
So tomorrow is our next meeting. That's a code enforcement coordination meeting. That's my staff, DCD's staff, Orca. Sometimes we have City of Shelton there and Fire Marshal go and they coordinate their code enforcement activities for properties that involve all the departments. So I don't know if that's the meeting you want to go to, or if you want to have a separate meeting with me, whatever works for your schedule.
I couldn't tomorrow, we're busy tomorrow.
It doesn't necessarily need to be that meeting, but
Well, and we
Depends
can,
on what time in the morning.
Yeah, I suppose.
Well, we
It's
can
9
set a
o'clock.
schedule for whatever is convenient. That's, you know, we can make that happen.
Yeah,
Well, so
can you-
I
can you
thought
do
it was
that?
more of a participation thing.
We could
over
make
time
9
anyway,
o'clock.
Not just one meeting,
that's
but,
true.
no, monthly.
yeah,
Yeah.
participate
Once a
over
month.
time, so just get
No,
some
ours
invites
is
out,
at 9.
for when the commissioners involved, we'll,
No,
No,
discuss
ours is at
when and
9.
how.
And Pam and whoever else.
We're used
Yeah,
to it, we
yeah.
do it every.
9 till 11.
Yeah, I just think it takes a
My
lot of
day's
the
confused.
the
Today is
mystery
Wednesday.
away,
Getting ready to
and
get on a Zoom meeting. so, no,
probably
this is
help you
public
too.
health.
You know, we've got a new board member from the tribe who has a master's in public health.
And that would be really nice
She's
to
not
have.
here.
She's not here, but I can reach out.
Yeah, that would be a good
That would be,
Good choice.
yeah.
It'd be nice to get some tribal representation, and get some, activity going.
Yeah.
Yeah,
So can you
because
send
it's
it?
very important to them.
Yeah.
Yep.
If you can send an email out to the
Whole
Board of
board,
Health.
yep, will do.
and,
So Pam, you have anything? We won't forget about you over there.
No,
Okay.
no, I'm just listening. I'm happy to attend on occasion, but I have to see what the schedule is before I could commit to monthly or twice a month.
Okay.
All right, thank you. All right,
Great.
then I guess put it together and get a hold of people.
Okay.
thank you.
All right.
Sounds good. All right, we're on item number 9, Community Health Report. Melissa Casey.
Good afternoon. Officially afternoon. Sorry, I
Well.
can't be there in person.
I'm glad you're not.
Thank you for that.
Yeah, I appreciate the opportunity to join you virtually. For community health, I really just have some really general updates for you. You might have noticed that the report that I attached to the packet is really thin this month. And there's actually a really good reason for that. We've been doing a lot of reflection and strategic planning in our department. Really something we started at the end of the year, coming into the new year. And we've had some really hard discussions. I think, for example, we've really talked about what the vision for our department is. Let's say it's to educate residents in the county so they have the knowledge, skills, and tools to make healthier choices for themselves. Are we actually achieving that? That's just one example. We've talked about all of our programs, and I think that there's really been the consensus among staff that we can really do a better job if it's not actually in really moving the needle and actually showing improvement in our programs. It's how we are communicating that we're actually doing that. So we're digging really deep. We're looking at contracts and ensuring that any contract obligations and deliverables we have, we're meeting that. Dave talked a little bit earlier about funding. It's not news that we are charged with maintaining the same level of service, sometimes even expanding services with very limited resources. And so how do we do that? We are evaluating program cost effectiveness. Are we maximizing our reach by being good community partners? Are we not duplicating services? These are the types of questions that we're really asking ourselves. Are we being efficient internally with our processes? So all of that work is really being done to ensure that we are really serving the people of Mason County with our programs, and that it's being done in a positive way, that we're not contributing to the negative things that maybe the public might see in some of the work that we do. Another thing is that some of our contracts are also at the state level have adjusted the metrics that they're using, so we're also in the process of reconciling that. And so all of this is really to communicate to the board that in the very near future, you'll see some changes to the community health report. I'm really looking to have more tangible data and reliable data that's really speaking to the impact of our programs. And it's an invitation to you as well. If you have specific questions or even, I think actually especially concerns with some of the programs that we have, please let me know. It is likely that we already have data that's just simply not communicated in a useful or meaningful way, but it's also likely that maybe we're not collecting data that would be important to you in making decisions about some of the programs that we have. So that's kind of the landscape of what we're looking at in the new year. There has still been a lot of successes that I did include in our report. We've had a lot of staffing shortages with our WIC program. But as you can see in the report, Rachel is still absolutely, she's killing it. She is still doing, I think it was about a little bit over 1,700 appointments over the last 4 months. That's just in 3 clinic days a week. We are continuing to grow our partnerships, very unique partnerships with a lot of the community organizations that have kind of started in the last few months. And then something that I'm also really excited about that will also potentially be something that we can partner with WIC on, but also a lot of other programs, the school districts, the libraries, is we finally have a Charlie cart. And I'm not sure if if you're not familiar with that, it's a really neat tool. It is basically a mobile kitchen. And it comes with all of the utensils. It has a sink attached to it, has an oven, the hot plates that you can cook. And I think in the last few months, with there being a lot of gaps, in SNAP Ed, for example, SNAP Ed went away. I think economically, people are struggling. How do you do more with less? How do you still eat healthy on a budget? So food resource management, nutrition education, these are the types of things that we really want to provide education for at no cost to our partners. We're in the process of really developing what this program will look like in terms of how we lend out the kitchen to community partners, how we might do some demos at the health department, and some other partners that we have. So I think there's a lot to come with that. And if you're interested in seeing it, please feel free to stop by. It's really big, and we kind of have it just in the hallway at Building 13. But we're really excited to show it off. And I think that's really kind of the highlights I wanted to share. Are there any questions?
Any questions for Melissa?
I have one. In your bats section, it says we had no positive bats during the fall season.
Positive for rabies.
I was gonna say, is that emotional? Is it?
No positive rabies.
Okay.
We get a lot of calls in the summertime. None of them were positive.
Okay. We gotta work on their attitude.
A little bit, they're a little negative.
Tell them don't drop dead.
Right.
All right, thank you, Melissa.
The next thing I had was we added the Kratom discussion. And
Right.
I have some information on Kratom.
that'd be perfect.
So if you want, do you want to go or you want me to go?
Well, let me just preface it that we had 4 bills around Kratom that came out, 6196,
Like five.
65. Okay. And you were up testifying yesterday.
I testified yesterday, yes.
So those are, I'll let you take it from there.
Well, basically, I was just going to tell you that, so Ben and I met with Dan Griffey regarding kratom, nitrous oxide, and other supplement concerns and solar gas stations, and he was very supportive of tackling these bills this year. This is the first time that we've seen any bills on these supplements. So there's like I think there's 5. There may be 6. Yesterday, I provided testimony on Senate Bill 6196, which aims to impose a regulation on kratom retailers requiring them to obtain licenses, undergo background checks, potentially face taxes as high as 95% of the product. There was about even Steven for and against vote count. I think they do a vote count there, but there was just me and another lady with the Department of Health that testified, and of course the kratom industry testified as well. I was going to testify today on 2532. I'm sorry, I'm not getting ahead of myself. I submitted written testimony for 2532 yesterday, nitrous oxide regulations. And tomorrow, which happened to be today now, I was going to testify on 6287, but I sent in verbal comments. And also House Bill 2291 will be on the 30th. Both of those bills require age restrictions. So the first one did not, but I made sure that they knew that that was a concern in that bill. So when these bills start getting tied together, that they understand that there's no other option other than age restriction with these bills.
We did the age restriction on most of them, or
Just
one?
the one that I testified yesterday was not. It was more of a tax and a license and a fee and background checks to sell the product. And then 6129 is coming. It's not on agenda yet. And then also Ben Johnson and other members of the coalition visited about every single gas station, convenience store, smoke shop in the county for voluntary compliance, and had really good support there to move stuff behind the counter and also to voluntarily age restrict. And I let the senators know yesterday that Mason County is serious about these products and how dangerous they are. So I'll continue testifying or supplying written comments. And do you have anything on that?
No, other than it's something we're tracking it with SALFO, and it's one of our legislative priority items around this. And so WSALFO is the Washington State Association of Local Public Health Officials. We'll be back in that. So
yeah,
WASC is doing the same.
Yeah.
There was a push, right, to eliminate it, but I think at this point, we need to worry about the age and the
Regulation.
kids
Yeah.
getting it too. It's like yesterday, there's it's not being regulated. There could be multiple versions of kratom that could be extremely dangerous, especially to minors, cause seizures, addiction, overdose. So, yep, I'm on it.
Yep.
And I asked advice a lot from Ben, Scott Walker, and Scott and John Holbrook, and so we're on it. We're going to make sure that our legislators know that we want this stuff protected from our kids. And Ben's here. I don't know if we have any questions about his talking to convenience stores or not.
Yeah, I'd like to just thank you, Eric, and Scott Waller, like you mentioned. And Jamie Taylor she sent in written testimony today, and it sounds like she may provide testimony on Thursday morning too. I think that's a really important piece. I know she's presented to this board in the past. So things are moving forward, and really, really, really hope at least they move it to 21 and older. Most of the convenience stores that we worked with have said that they'll only sell it to 21 and older. Of course, the vape shops, you have to be 21 to get in there anyhow, so I think they're doing pretty well. The piece that we ran into that might be the most difficult is bringing down their outdoor signs. The store at Hood Sport, she said that she'd taken her signs and move everything behind the counter and only sell to 21. That was a big one because I had asked the clerk specifically, if I were to walk in right now and ask for this, and I was 18 years old, would you sell it to me? And he said, yeah, there's no law against that. And I ended up talking to the owner, and she said, nope, we will change it. So things are moving on, and hopefully it works out well this year of the state to kind of take care of this.
Thanks, Ben.
Thank you.
Thanks, Ben.
All right.
I think that does it for us, other than public comments.
All right. Does the board have any other issues to bring up? All right. We're now at our public comment stage, item number 11. Is anybody in the public here to speak to us? All right.
I just wanted to thank the board for their decision not to proceed with that code enforcement deferral policy. I think it's a good idea not to proceed with that. I've spoken ad nauseum about the issue, about how it created a radiating harm on neighboring properties, both in the instance that I was involved in and my neighbors who came in to speak. There seem to be two reasons why we got there. It seems to have been an unwritten policy prior. One, perhaps, is funding, that there's limited funding and the choice is to do the programs that these departments want to do to help people, or do code enforcement, which is a big money suck. The other was homelessness, which I'll get to in a second. With regard to the money issue, that's always going to be there. That's government, that's small counties with limited funding. There obviously has to be some kind of pressure to keep this from backsliding into a default policy again. The best thing I can think of that I can do to prevent that is to simply pull public records once a year on all the septic code enforcement cases and just agglomerate them on my website so people can see what percentage were adjudicated, what percentage were discarded, what the details were, and they can make a decision as to whether the preponderance of the cases are being adjudicated correctly or if it's reverted back to a policy of just don't enforce, don't enforce, don't enforce. That gives other citizens tools that I did not have and that my neighbors did not have when we suffered through what we went through. But if the motivation was regarding homelessness, I think there's a lot that we can move forward on. I saw Ms. Casey's presentation a few months ago about homelessness. They had some good plans, some bad plans about short-term rentals, but the ideas about building affordable housing seemed like a good idea. And in that line, because I had mentioned before that perhaps expansion of mobile home parks where people could bring their RVs, render them non-mobile, and live in accordance with code and have proper sanitation would be a good route. Incentivizing multifamily units, which are hard to do here because there's not a lot of infrastructure they need to be on sewer, not septic. I brought an idea to Ms. Casey and to Ms. Rowan over at Community Development that was actually emailed to me by Pierce County. I can't unsubscribe from their emails for some reason. I lived in their unincorporated area for 10 years, which is a cautionary tale of uncontrolled growth. They are doing something called cottage housing. It looks like a mobile home park, except they're stick-built homes. They're small, they sit around a central courtyard, and there's two types. One where they're self-contained and the courtyard is just for a community space, and others to reach an even lower income group. They don't have cooking facilities, they share a kitchen, a community garden. What that does is it creates a type of affordable housing that is profitable for developers, so they'll actually come build it rather than have to be incentivized. It's an idea, it's something to move forward to, and maybe that's where we can start to move in that direction instead of just letting people fall into squalor, which was what the other policy was doing. So hopefully positive changes.
Get your name and where you're from.
Oh, Ryan Finn, taxpaying citizens of Golden Pheasant.
Thank you. And that is in the city's policy, those cottage houses or tiny villages. We actually have one in the Veterans Village.
Okay.
35 homes and a shared kitchen and, yeah.
The thought was perhaps in some of the areas that aren't served by sewer, they might be amenable to a septic system if done right with the appropriate monitoring, because you get the number of bedrooms seem to match up with a very large sewer system, might allow them in more areas. I understand from Ms. Rowan they can't be in the outside the urban growth zone, but there's a lot of urban growth area that's served only by septic and not sewer. So
thank you.
More options.
All right. Anyone else? No? All right.
What about Leo?
He's already snored, yeah.
Yeah. All right. No other discussion? I'd take a motion to adjourn.
I so move.
I'll second.
Motion is second to adjourn. Aye.
Aye.
All right. Adjourned. Thank you, Pam.
Thanks, Pam.
Thank you.